Good morning. My eyes aren't as good as some of these younger doctors that preceded me here, Dr. Eisner and Dr. Chipman, so I'm going to be looking at my computer as we go along here. Also, the slides that you have, I've updated them, so I think they're going to be on the website. So some of the ones that you have are kind of like from an old deck, and so this is the latest. And so Grace assures me that there's going to be an edition coming out on the web, and that's the slide deck I want you to look at. But my name's Larry Karsh, and I have the privilege of being here this morning, being invited by Beacon, and also being on one of the members of the Bladder Cancer Think Tank under the direction of our new leader, Larry Rezepka. So it's really an honor to be on that panel. You have a great cast of speakers here today, Dr. Chipman, Dr. Eisner. You're going to hear from Drs. Wilson, Flagg, and Dr. Theodescu. And we're very lucky to have them in our neighborhood. They're world-renowned experts, and Dr. Theodescu actually, from the time that he was a little boy, his goal was to find the cure for cancer. And so he's a very gifted and passionate physician, and he's doing a lot of research, and so I think that we have a lot to look forward to from him. And I have kind of a less lofty goal, and that is that I'd like to see the cigarette packages say that cigarette smoking can cause bladder cancer. We know that that's a fact, but it's really not on those packages. And it's amazing to me how many patients that I diagnose with bladder cancer that tell me that they didn't know that smoking caused bladder cancer. So I think just an awareness would help. And so you can write the Surgeon General and tell them that you'd like to see that on those cigarette packages. Now, I practice at the Urology Center of Colorado. We're located right across the street from now the Sports Authority field. We have all outpatient urology services under one roof. We have 17 doctors, 15 urologists, and 2 radiation oncologists. And the reason that I put the little blue shoe run out there is because it's going on right as we speak, and it's put on by our foundation for prostate cancer. So that's why I probably won't be here this afternoon. I'm going to try to attend that if I can. So you're going to see a lot of repetition here as far as the slides, but the more repetition, the more you're going to learn. We're going to kind of drill all of this into your head, but bladder cancer is the most frequent malignant tumor of the urinary tract. The ratio from males to female is 3 to 1. It's the 4th most common cancer in men and the 8th most common in women. And according to the American Cancer Society, it was estimated that there are 70,530 patients, new cases that were diagnosed in 2010, and 14,680 deaths from bladder cancer in 2010. The most common ages are 50 to 70, but any age can get bladder cancer. And the most common type is transitional cell. So looking at the natural history and at the diagnosis, 70-80% are non-muscle invasive at presentation, 60% are low grade, 40% are high grade, 50 to 70% will recur at 5 years, 10 to 30% will progress to muscle invasive cancer, and at the time of diagnosis about 5 to 10% are metastatic. And low-grade cancers can develop into high-grade cancers, and so that's why it's important for us to do surveillance and do it pretty actively to make sure that we're not developing worse tumors. So the cell types are transitional cell, greater than 90% in the bladder cancer in the U.S. Squamous cell is another bladder cancer. It's less common In the United States, it's associated with chronic Foley catheters, stones in the bladder, chronic inflammation. And so that's what these stones and chronic Foley catheters can do, and that's why patients who do have catheters, we like to at least look in their bladder once a year. In Africa, there's another cause for squamous cell cancer, and that is a parasite called schistosoma. And that's endemic in the water, and you see it a lot in Egypt. But schistosomas can cause squamous cell bladder cancer. And adenocarcinoma is another subtype, and as Dr. Eisner mentioned to you, there are a whole bunch of different subtypes. There's micropapillary, there's small cell, and then we have sarcomas that are generally seen in the pediatric population. So transitional cell cancer can occur anywhere along the lining of the urinary tract. So as opposed to a kidney cancer which grows into the parenchyma or the outside of the kidney in that kind of the meat part of the kidney, transitional cells are a different kind of cancer, and they grow in the lining. And as you can see, it can be anywhere from up in the renal pelvis, the kidney, all the way down into the bladder. And the the occurrence is 50 times more in the bladder than in the ureter, as well as in the kidney. It's 50 times. The ratio is 50 to 3 to 1, and the reason that it occurs like that is because it really depends on transit time of the urine. It depends on how long that urine sits in the or is exposed to the urothelium. And the urine generally sits in the bladder longer than anywhere else in the tract. And the reason that you have less of it occurring in the ureter is because the urine is going pretty rapidly down the ureter, and so there isn't a lot of time where it stays in contact with that urothelium. And with bladder cancer, 4% of those can have an upper tract cancer, so and that's why we look at imaging studies to look at the kidneys and the ureters. But when you have bladder cancer, you have about a 30% lifetime risk of developing an upper tract tumor, meaning in the ureter or in the renal pelvis, as we call the inside of the kidney. And if we find an initial upper tract transitional cell cancer, you have about a 40% chance of having that also in your bladder. And there's a good chance that from an upper tract tumor that you're going to develop a bladder cancer, because those cells seem to shed and get down into the bladder. And so that's why it's important for us to do surveillance, and I'll show you a few guidelines as we go through the lecture. So the risks are that smokers are at about a 4 to 5 times greater risk of developing bladder cancer, and it increases with a number of cigarettes that you smoke and the years that you've been smoking. And there's some debate as to whether or not, if you quit smoking, when do you lose that risk of developing a cancer? Well, we think that it may take 25 years of stopping smoking before you're really free of it. There was a study in 2000, I think it was a Journal of Internal Cancer, or a cancer journal, but they said that the relative risk after stopping after 4 years, the relative risk of not developing cancer is you reduce that by 40%. So that if you quit smoking at 4 years, that you'll reduce that risk, and it's pretty significant. So the bottom line is quit smoking. Or don't even start. The other things that can cause bladder cancer are aromatic amines, aniline dyes, and these are the chemicals that are in that hairdressers use, photo processing, painters, truck drivers, textiles, chemicals that you get in the leather goods or rubber industry making tires. Some of the drugs that have been associated, one was phenacetin, which is a non-steroidal anti-inflammatory pain reliever. It's no longer available, but it was used pretty frequently before it became illegal, and the reason it is illegal is because they use it to cut cocaine. Cyclophosphamide, another drug that is used as a chemotherapeutic agent for leukemia, lymphoma, that has also been implicated in causing bladder cancers. And if you have a history of pelvic radiation, like radiation to the prostate or the cervix, there is a chance that down the line you could develop a bladder cancer. And as we mentioned before, chronic irritation from catheters can cause squamous cell cancer, so we really need to be vigilant with those patients. This is kind of a funky slide that I have to work on here now. So the presenting symptoms, and I think that Dr. Chipman went through this, but hematuria, or blood in the urine, is usually the first symptom. Usually it's asymptomatic. It can be gross where you see it. You know, you may see kind of a cherry urine, a burgundy, a Coca-Cola. That's a sign that you need to get to the doctor. I mean, a lot of people that I see tell me that, well, you know, I noticed that about a year ago or 18 months ago, and it went away. So I thought it's okay. But that's something that needs to be looked at, because the sooner we can get to it, the better our prognosis will be. Bladder irritation. Sometimes patients come in with this urgency and frequency of urination. Of course, we're going to rule out a urinary tract infection, but we also think about Carcinoma In Situ, which I'm going to explain to you in just a little bit. But it's a high-grade cancer that grows just in the very superficial lining of the bladder. And if you have back or pelvic pain, that could be a bad sign, because it could mean that you've got obstruction of your kidneys, and that usually portends that you have a higher grade kind of a tumor. So what is the workup for bladder cancer? It's pretty simple. We do an imaging study of the upper tract, and we look inside the bladder. Now, we go through our normal steps of a history. We look at risk factors, cigarette smoking, exposure to chemicals. We do a physical examination. We try to decide whether or not that bladder's fixed in the pelvis or not. If it is, it means it's probably a higher grade kind of or higher stage cancer. We look at the urine. There are a number of tumor markers out there. Nothing's perfect, but we have something called BTA, NMP22, and these are things that we can do a spot test right in our office. They're not perfect because there can be false positives from an infection, a stone, irritation in the bladder caused by overactive bladder, things like that. But these things are not perfect. The cytology is something that we actually look at cancer cells in the urine, and this takes specialized kind of preparation, and talented people like Dr. Eisner look at that and tell us whether or not they think it's suspicious for cancer, or it actually has cancer cells. The downside of the cytology is it doesn't really pick up low-grade cancers. It's pretty good, though, for carcinoma in situ. It's a very reliable marker for that. And the upper tract studies that we use are CT urograms, IVP. What you see there is an IVP, and you can see that it demonstrates the inside lining of the kidneys. You can actually see the outline of the kidneys there, too. Takes it down to the ureters and into the bladder. So that's what we do to assess. And now we have a CT urogram, which can actually take a CT scan, and it can turn it into a picture like this for us. It's become more sophisticated. Ultrasounds can be used, but they're not as accurate. A lot of false positives. MR scans. We're trying to devise some better agents and contrast agents, but sometimes it can tell us a little bit more about the invasion of the tumor into the bladder. And then when it comes to cystoscopy, the standard has been white light, and that's what we use. The fluorescent cystoscopy is a newer type. It takes a little bit more technology, and we have to have the patients ingest an agent, a fluorescent agent that allows visualization of some tumors that we can't really see when we're looking with the white light. These agents get picked up by high metabolizing cells, and sometimes we'll have some cells like a CIS, carcinoma in situ, that are difficult to see just with our own eye, and what it does is it'll light those up for us and turn them a fluorescent color that we can see with a cystoscope. Now, the different visual types, we have exophytic, which grows into the lumen of the bladder, not into the wall of the bladder, but into the lumen, so that I'll show you some pictures here. But they can be papillary, which kind of looks like a little raspberry, or sessile. Those are a little bit more ominous because they usually grow into the wall. And then there's carcinoma in situ, and that just grows along the surface. And carcinoma in situ can appear as a velvety or reddish area. It looks like inflammation. Sometimes we can't tell exactly when we look in there, and that's why we have to do biopsies. But it can be asymptomatic. It can be associated with what we call lower urinary tract symptoms, which are urgency and frequency of urination, urge incontinence. Those kind of symptoms in patients can sometimes mean that they have a carcinoma in situ or a cancer. Cytology is very good at trying to pick up carcinoma in situ. That's where we have the pathologist look at the cells in the urine, like I described before. And carcinoma in situ can also be associated with other high-grade tumors. So you may have multiple grades of tumor in your bladder when you present or as time goes on. And so that and 40 to 80% of these carcinoma in situs will progress to muscle-invasive cancer. Metastatic disease, it travels up the lymphatic system. The lymph nodes are the little traps that drain each organ, and tumor will be part of that gets drained into these lymphatics. You can have spread through the blood system, and then it can get into the liver, bones, lungs, adrenals. And so the way that we evaluate for metastatic disease, again, we use CAT scans, and when we're trying to see the interior of the kidneys and the lining of the ureters and the kidneys, we use the CT urogram. We can combine that all into one study. Chest x-ray is a good way to see whether or not there's some tumor in the lungs, MR scans, bone scans. We look at blood tests to assess liver function and alkaline phosphate, and that will tell us whether or not we're suspicious about a liver tumor. And also alkaline phosphatase tells us about bone involvement. So how do we treat non-muscle invasive bladder cancer? Well, the first thing we do is a transuretheral resection. And that's where we go into the bladder with a scope and we get the tissue out, and we can make the diagnosis. We can try to stage the cancer and treat the cancer. And the standard way to do this is with the electrocautery, which I'm going to show you in a minute. Another way is the laser. It can destroy tissue, but the problem with the laser is unless you're getting biopsies at the same time, you're not going to get a pathologic evaluation. They say there's less bleeding, but it just depends on the size of the tumor as to whether or not you're going to have bleeding with it. And so we go through the first step, that's to resect the tumor, and if necessary, we have intravesical therapy where we put medicine into the bladder through a catheter. And then if patients need more, cystectomy. Usually for non-muscle invasive bladder cancers, we're not doing cystectomies unless you have something like refractory carcinoma in situ, it keeps coming back, or you have high-grade tumors that keep coming back. These tumors may progress into muscle invasive, and that's why we recommend cystectomy in some of these patients. Systemic chemotherapy, there's really no role for it in non-muscle invasive bladder cancers, and not a role for radiation in non-muscle invasive bladder cancers. So this is what the resectoscope looks like. It's a scope that we go into the bladder, and it has a little cutting loop on the end, as you can see in that top corner. and that's the electrocautery, and that's how we scrape that tumor out. And also at the same time, especially on the initial diagnosis, or if we have any question, I will go in and do a cold cup where we take a sample of the base of that tumor, because when you use the electrocautery, you're actually distorting a lot of these cells, so it makes it tough for doctors like Dr. Eisner to tell exactly whether or not that tissue is invading and what it looks like, because we're actually destroying it. So we do a cold cup biopsy at the same time. And this is what it looks like. You see that little papillary tumor up in the right-hand corner. That's what these little cancers can look like. The loop in the bottom left, that's how we scrape it. And at the end, we have it all scraped out, and that's what it looks like at the end of the procedure. So there are risks, though. Anything we do, whether we give you an aspirin to take or doing an operation, there's always a risk to any of these things. The risk with the TURBT is that we may not get a complete resection. Sometimes we have to go back in, depending on how big that tumor is. Sometimes we have to go back in and restage it. You can get a bladder perforation, and that means that the loop or the laser will go right through the bladder. It's a thin wall. When it comes down to it, we're filling it with fluid. The wall gets thin, and we're trying to get as deep as we can to make the best diagnosis and also to get rid of the tumor. And sometimes you can have a perforation. So if that happens, you might get pain. You'll see decreased urine output with or without a catheter in place. And so what has to happen there is that we leave a catheter in until the bladder heals. There can be damage to the tissue just from doing these procedures. There can be scarring. You can block a ureter. That's the where the ureter meets the bladder, the little orifice, the opening. You may need to have the Foley catheter stay in after you have a TURBT. Sometimes because men can't urinate. They may have enlarged prostates, and so after going through a procedure like that, they sometimes can't urinate. You can also have bleeding that will cause clot retention, and in that case you'd also have to have a catheter. And you can get infection, and also you can have recurrences. Now, the grade and aggressiveness, I think that's kind of gone over, but the old system was calling it grade 1, 2, and 3, and this is how we assess how aggressive the tumor it is. The new system is low grade or high grade, and so low grade kind of incorporates the old grade 1 and 2, high grade is 3, and pun lump is something that is really now considered a benign tumor. We used to call these low grades, but it's a papillary urothelial neoplasia of low malignant potential, and that's what pun lump stands for. And the most important risk factor for progression is the grade of the tumor. And you can have more than one different type of grade in your cancers at the time of diagnosis. And then when we get to staging, again, you've heard about this, but we have stages from TA to T4. For non-muscle invasive bladder cancer, we're really focusing on TA and T1. Those are the ones that grow into the superficial lining of the bladder. The T2 invades the smooth muscle, T3 invades the fat surrounding the bladder, and T4 invades other structures in the neighborhood, like the prostate, seminal vesicles, uterus, vagina, and even can invade into the abdominal wall. So this is the bad guy. I don't know if any of you remember Boris Badenov, but this was one of my favorite cartoons in the past. But it's Carcinoma In Situ is, although it's superficial, and it just grows on the lining, and you can see up in the upper right where it says TIS, CIS, it is in a very superficial location, but it's a high-grade, very aggressive kind of a cell type. And it's 25% of high-grade cancers, so meaning that, that they're high-grade cancers. They can also have CIS in them. And 70 to 80% of muscle-invasive tumors have carcinoma in situ. But there is about a 50% response when we use treatments such as BCG, which I'm going to explain in a little bit here. And this just kind of goes through the grade and staging system, so that the deeper that tumor goes into the bladder or through it, the higher the chance is that you have spread to distant sites like the lungs or the liver. Again, you can see the TIS is way over here, but that's a pretty bad actor, and we've got to try to take care of those tumors. So we explained to your health insurance company that you need a very expensive surgical procedure or you'll probably die. They're now negotiating with your life insurance company. So how do we manage non-muscle invasive bladder cancer? Well, for the low-grade TAs, if we have less than 3 small tumors, we may just watch that, or we may decide to use some therapy, intravesical therapy, where we insert the medicine into the bladder through a catheter. And I'll explain a little bit more about that as we go along. High-grade and or T1 tumors. Again, these are all the non-muscle invasive. We really have to go in, when we get a high grade or a T1, we should go in and resect again to try to confirm that it is truly a TA or a T1 tumor and that it's not more aggressive than that. And so if we confirm that, then we can consider intravesical therapy. Carcinoma in situ is a high-grade, very superficial or TA tumor, and BCG is very effective for that. Now, if you have recurrent high-grade T1 tumors and they keep coming back, we may want to consider a cystectomy. That means taking out your bladder. If you have recurrent carcinoma in situ that's been refractory to treatment, we also may want to consider a cystectomy in that situation. So the way that we manage this is with the intravesical therapy. And vesical is bladder, intra, we're going into the bladder. We place the medicine directly into the bladder, and there are about 3 different scenarios for this. We can do it immediately post-op, so that right after surgery that we resect the tumor, we can put some medicine in. And the rationale is to decrease seeding of tumors that might be floating around, tumor cells, and prevent recurrences. Now, it's not an absolute guideline here in the United States that we have to do it. It's recommended that we do it. There's been some studies to show that it does decrease seeding and recurrences. But after the post-op, after the operative period, we sometimes do a course of intravesical therapy. And that would be an immediate, or not immediate, but a post-op induction. Usually we wait about a couple weeks, and we can do a series of 6 treatments once a week, and that's an induction. And then we can go on to maintenance. And there's really nothing proven to say what's the best way to do this. I'll show you something that I do that I think has been adopted pretty well across the country. But you do the induction, and then we do maintenance courses, a series of 3 every 6 months for about 3 years. So we try to do that to decrease recurrence and progression. In carcinoma in situ, again, remember there's a 50% cure rate, but if you're refractory to that, we have another drug. It's a newer one on the scene called valrubicin. It has about a 18% success rate, so it's 1 in 5 that it will get rid of that. And if it doesn't, then you may need to consider cystectomy and removal of the bladder. And as far as the different types of medicines, there are different classifications. There's immunotherapy, BCG is part of that, as well as interferon. And then we have some chemotherapeutic agents like thiotepa, mitomycin, doxorubicin, now valrubicin is another one. And as far as the FDA approval, well, BCG has been approved by the FDA. Thiotepa, which is something we're not really using that much anymore. I remember years ago we used to use it before there was mitomycin. And then there was a shortage because they were using it for bone transplant patients. And it doesn't work as well as the mitomycin. But although mitomycin is better, it's never really been FDA approved, even though it's probably one of the most commonly used medicines in the bladder. And Doxorubicin also is not FDA approved, but we use that. It's not as effective as mitomycin. And Valrubicin was the newer one that was approved a few years ago, and that's approved for recurrent carcinoma in situ. So BCG, this is approved for carcinoma in situ and recurrent TA and T1 tumors, non-muscle invasive tumors. So there's a downside, as I mentioned before. 60–80% of these patients can develop cystitis, and cystitis can manifest by pain, urgency, frequency, bleeding. These things can occur just from the treatment. It's the most effective, but it does have the most risks. But it does decrease recurrence by about 40%, and it is even shown in some studies to decrease progression by 27% if used in the maintenance setting. And these are the BCG is Bacillus calmette-guerin, and these were some French scientists that actually developed the tuberculosis vaccine in 1921. And so what we've done is kind of reformulate it to be a weakened or an attenuated kind of a bacteria. And we've been using it probably since the 70s. And it really didn't start gaining a lot of popularity until the 80s. But what it does is it produces a inflammatory reaction in the bladder, kind of sloughs out the lining, but it also revs up the immune system, and it has your system try to fight these tumors off. And I'm going to show you some of the new investigational drugs that we're looking at, and there's a new immunotherapy that is in investigation as part of a study. But I think that's the wave of the future, and it gets much more specific than what BCG can do, because it's really designed and personalized for your own immune system. But right now, BCG is the most effective intravesical agent, and it is superior for carcinoma in situ. And this was a SWOG study that showed on maintenance that 6-week induction, you get it once a week for 6 weeks, and then 3-week maintenance at month 3, 6, 12, 18, 24, 30, and 36, so that after the first induction and the next maintenance at 3 weeks, it's really happening every 6 months for 3 years. And so they did this study to compare this to no maintenance, and where they just had the induction with no maintenance. And with no maintenance, the patients had a 36-month, close to 36-month recurrence-free survival. With maintenance, there was a 76.8-month recurrence-free survival. So it does show some benefit. The problem is that only 16% of these patients completed the study. And sometimes patients have to drop out because they're having a lot of symptoms from this agent. Now, we also use interferon that we can add to BCG. And why we do that is because we can decrease the dose of BCG and add the interferon, and this can help decrease the side effects. If some patients can't tolerate it, we try to do things to decrease the side effects. We also even decrease the dosage of BCG, and we might do that in single use or in combination with interferon. And this is usually a regimen that we might use if you don't respond to BCG only. We might try BCG and interferon. I think it's probably a better combination than just the mitomycin alone. So, my side hurts, Dr. Zook. Of course it does, Hager. Remember how I said the medicine you took might produce side effects. Now, BCG, of course, we talked about some of the downside. There's sepsis. And now, fortunately, it doesn't occur real often. It's about less than 5% of the patients. But there are different grades, and it can be grade 1 to grade 3, and it can be anywhere from just having a fever to a little bit of burning, requiring a nonsteroidal anti-inflammatory like Advil or ibuprofen and a medicine to relax the bladder, all the way to like a grade 3 where you're getting persistent high fevers and you've actually got a tuberculosis infection brewing. It could be in the liver, the lungs, and you may have to be on the antimicrobials. Good thing is we have cures for tuberculosis nowadays. And isoniazid and rifampin are probably the leading drugs that we use for tuberculosis. But depending on how bad that sepsis is, you may have to be on some medication for that. Mitomycin-C, that's considered a cytotoxic chemotherapy. It's actually a chemotherapy that you can use intravenously, but we've adapted these to the bladder. It's probably the next most effective drug. It's given immediately post-op, and you can use it for maintenance. It's the choice in patients in whom BCG is contraindicated, people that can't tolerate BCG or they have a compromised immune system, or various reasons for why they can't be on BCG. And patients who do fail BCG therapy, we consider Valstar. Again, it has about an 18% success rate, 1 out of 5, so it's not great, but it's out there, and in some cases we'll try it. Thiotepa, I mentioned to you before, it's not used as commonly anymore, but it can also be given post-op. Problem with Thiotepa is it can get absorbed through the bladder into the system, so that we have to get a white count and platelet counts to make sure that it's not dropping your white count or inhibiting your platelets. Doxorubicin can be given post-TURBT, but a SWOG study demonstrated that it's not as effective as the other agents, so we don't use that very much. Valrubicin is the newest. It's a synthetic doxorubicin. It's been approved for CIS patients who are BCG refractory. A lot of our patients who cannot tolerate surgery, we will try giving them this drug, valrubicin. And in some patients who are refractory to patients that require cystectomy, but their health isn't up to it, we have some other options, which are radiation and chemotherapy. Again, that's a discussion for later talks this afternoon. We're just talking about the non-muscle invasive bladder cancers. And these are some of the investigational trials that are going on at TUCC. We're looking at a SWOG, Southwest Oncology trial, and looking at Gemcitabine, which has also been a very effective intravenous agent for cancers. We put that directly into the bladder like we do with the other intravesical therapies. And it's just looking at giving 1 dose right after surgery versus placebo. And these are for low-grade cancers. And so that study is in progress. We also have done studies with a drug called apaziquone, which is very much more potent than mitomycin. It's in that same family. We have done just a post-surgical trial with that, and now we are involved in a maintenance trial called the SPI 1011, and that's looking at 6 doses of maintenance after your 6 induction treatments after we do the initial post-operative insertion. Dendreon is a company. It's one of the genetic companies that has devised immunotherapy. They have had the first immunotherapy approved this last year for prostate cancer called Provenge. You hear that? And it's on the market. Well, they're also doing the same process, looking at different tumors. And what they do is they design a immune therapy that actually tunes your own lymphocytes or T cells to become very active against the tumor cell. So what they do is they take white cells from you. It's called a pheresis. It's like giving a blood transfusion. Take that, we send it back to their manufacturing facility. they mix it up with some different compounds and GM-CSF and just these things, and they have certain, for the different kinds of cancers that they're looking at different antigens that are in those cancers. And so for bladder cancer, they're looking at this therapy. And then what they do is 3 days after you have your blood shipped off, and they process it, then they send it back in the formulation that we infuse back into your system. They do that once every 2 weeks for 3 treatments. And they're trying to see whether or not this increases overall survival. It did show their CYP-T, which was the drug that they had approved for prostate cancer, did show an increased survival. This is really limited to patients who have just had surgery, within 6 weeks of surgery, anywhere in the urothelium, anywhere in the renal pelvis, the ureter, the bladder, then you, and if you have the HER2 positive receptors, then you will qualify for that study. There's another intravesical agent, EN3348 study from Endo, and they're looking at a mycoplasma cell complex, which is kind of like BCG but not BCG. But it revs your system up to recognize it like it does BCG. And they're doing that in comparison to mitomycin for BCG recurrent or refractory non-muscle invasive bladder cancer. So that's a trial that we have ongoing at our center now. These are the trials. And so as far as follow-up, it's the most expensive cancer to monitor at a minimum. We do cystoscopy every 3 months for 18 months, then 6 months for 18 months, then yearly for life. Once you have recurrence, we restart that cycle all over again, and we use periodic tumor markers or cytology, and we get periodic upper tract studies. The National Comprehensive Cancer Network has recommended every 1 to 2 years for high-grade tumors that we get an upper tract study. And as far as the surveillance, the recommendation, 2010 recommendation from the NCCN is cystoscopy every 3 months for 1 to 2 years. They're not really clear on, do you do it for 1 or 2 years? I think it's at our discretion. Then every 6 months for 2 years, and then they say yearly. And what does that mean? Does that mean 5 years, 10 years, infinity? I think, in Europe, the EAU, the European Urologic Association, they recommend just 5 years and then stopping. We basically go on longer, and depending on what kind of tumor type the patient had, I think we still need to keep looking, and I might extend it, after 10 years, every couple of years to look. And then the upper tract studies every 1 to 2 years for high-grade disease. And the AUA guidelines, 2007, the standard is to repeat the TURBT in all T1 tumors because there are staging errors in up to 30 to 50%, so that it's actually upstaged because we missed tumor in the muscle. The recommendation for intravesical therapy is that they recommend that we give a dose of the intravesical chemotherapy right after the surgery. And with low-risk patients treated, you can do an induction and maintenance with BCG or Mitomycin-C, depending on how many tumors they had and how what the doctor feels is necessary. High risk, we do induction therapy and maintenance therapy. And in high-risk patients, that you may want to consider cystectomy if these treatments do not, they fail, so that patients may eventually come to having their bladder removed. So what can you do? Stop smoking, change your occupation, low-fat diet, increase your fluid intake so that you can dilute the carcinogens in your bladder. Again, that's been controversial. No studies have really proven that. And so if you're this guy, I would strongly recommend that you quit smoking cigarettes, because it will cause cancer.